So Daraius actually is representing Cyrus. Cyrus was supposed to speak, but Cyrus is not.
He wasn't able to make
emergency, and Daraius is a prolific vitreoretina surgeon from Delhi. So welcome, Daraius.
So I'm sorry to present this before lunch because it's going to make you very hungry, because I'm going to talk about HAM in amniotic which is human amniotic membrane in macular hole surgery. So like Curious George, I was always curious to use HAM in amniotic membrane. Tried a couple of times, failed, and found it very difficult to use. Why? There is challenge in visualization. It's thin and translucent, difficult to see. Sometimes you lose the graft. And high myopes, there's very little contrast. So it's difficult to see the membrane. And when you can't see something, it's difficult to use that particular item. Sizing it, we tried cutting it inside, we tried cutting it vanas, then we tried cutting it inside the eye with our curved scissors. It was arbitrary. I was not happy about it. Placement. It sticks to the forceps because there's a chorion side. It's very sticky. And it's not very elegant to keep on trying to shuffle it inside. And then to put it accurately, and then you're trying to shove it into the hole, you're going to cause damage to the RP. So, our principle is do no harm first, as our Hippocrates oath says. So that's what we try to strive for. So I was really frustrated. I discussed with my friend Dilraj Grewal because he had worked on the neurosensory graft. So we worked a workaround for each of these techniques. It's a fun video. Feel happy to, you're allowed to laugh out loud if you find it funny. So here it goes. It has a voiceover. Can you put on the video, please? Sorry.
Surgical toolkit for HAM grafting in VR surgery. Dr. Rizzo's group recently described the brilliant concept of human amniotic membrane or HAM grafting for recurrent macular holes. However, there is hesitancy in adopting this technique due to difficulty in visualizing, handling, and placing the graft.
Hi guys, hope you're well. So I'm going to hold your hand through preparing, making, and roasting the most amazing Christmas roast ham.
Let us guide you through our recipe for ham in VR surgery. We depict a surgical toolkit using 3 S's: staining, sizing, and sliding. First S, staining. It is true that the amniotic membrane is indeed difficult to see. It is white, translucent, and thin. Simply staining it with a few drops of brilliant blue dye solves the problem. Second S, sizing. We need to determine the graft size and then cut it neatly and accurately. We use inexpensive, disposable dermal trephines. We measure the macular hole indices preoperatively on OCT B-scan. After some trial and error, we found that the optimal graft size is roughly the average of the sum of the minimum linear diameter and the base diameter. See how easy it is to get the perfectly sized graft with a dermal trephine. Third is sliding. Accurately and atraumatically placing the ham graft is a major challenge. We use a bimanual sliding technique with a Tano brush and a nitinol flexible loop. Let's see a few cases. The 62-year-old lady presented with failed macular hole surgery done 2 months ago. See how nicely the graft slides in with the bimanual technique using a Tano brush and a finesse loop. Post-operatively, the hole is closed. This RD case came post-operatively with an attached retina but had developed a macular hole and oil emulsification. We did a silicone oil removal and bimanually placed a ham graft into the macular hole. See how beautifully the hole has closed. This was a failed macular hole case who developed a total retinal detachment with vitreous hemorrhage. In such cases, we place the graft under PFO or after fluid air exchange. You can see how we bimanually slide and spread the graft and place it accurately under PFO. Post-operative OCT shows that the retina is attached and the macular hole is closed. This was a very high myope with a posterior pole retinal detachment and a macular hole. In this case, we slit in the ham after fluid air exchange. In such cases, we take the graft size to be twice the MLD. See how scary the pre-op OCT was and how nicely the retina settled with a ham graft.
Look at this. Luscious. There is no more festive sight than a glazed ham.
With the Triple S technique, we provide you with a toolkit and our recipe for the perfect ham graft in VR surgery.
So that's it. Thank you.
Cyrus, in the first case, you put it below the hole.
Yeah, so
Over the
that's
RB, I thought you should have put it over, no?
no. So there's the two techniques. There's the overlay and there's the underlay technique. And I initially did the overlay, burnt my fingers because when it dislocates, it's really bad for your ego and for the patient. So now I do a very gentle underlay because I think it sticks longer. A second advantage of underlay over overlay is people who are doing overlay, even in the US, some of them are putting PFCL for some time or oil or heavy oil. But with this technique, you can use gas very easily.
And I
So I think-
presume you peel the ILM in all cases prior putting the graft, or you don't peel the ILM?
So initially, I'm basically doing it for refractory cases in which the ILM is already peeled. Like that case with that RD was a young man from Ladakh, and I think Dr. Cyrus is very particular about peeling. So he had peeled arcade to arcade ILM. Then patient came back. There was all this trouble in Kashmir and all. He came back after 2 years, and that time he came with a total RD and vitreous hemorrhage. So we didn't know what went on. Then on the table we saw I said there's no ILM at all to be found because ILM was peeled in the first surgery. So all the cases had already got the ILM peeled.
And what is the vision improvement in these patients, and how many cases you have done with this?
So that's it's a mixed bag. I think the first case I did get something like 6-12 parts vision, but overall, since these are patients which are really, really bad, I don't promise any vision. We just do it to close the hole. And secondly, in high myopes with RD, I think getting an anatomical result is only so difficult. So I think it's mainly, it is a good scaffold. It works as a good kind of bandage, and it kind of lets the retina settle. Vision is not so great in most. So maybe 1/3 or 25% get good vision, maybe about 6-12, but the others maintain vision, or maybe some vision may drop also. So,
How many cases have you done? And you on OCT, what we can see in hyper-reflective shadow.
yeah.
So we know the amniotic membrane do degrade over a period of time. And when did the amniotic membrane degrade over a period of time?
So I think we have about 3-year follow-up, and it still looks white and shiny every time the patient comes. I don't know when it's going to degrade. I've spoken to some people in the US and all. They also said that they'd see it. I think Dr. Nayak from LVP has a good experience, Dr. Samira. So she also told me at VRSI that it doesn't go away.
So if it doesn't degrade, then how does the vision improve? Because the retina...
The cells migrate over, and in one of them, you see the lines coming above it. Yes, we could.
So I have a question for you. So when do you say after 6 months, 1 year, that now no more vision is going to improve? Do you have a cutoff? Because with the 19 cases which was shown by Dr. Rizzo, who initially did it, they have a certain time frame. If the amniotic membrane stays there for 3 years, you have to have a cutoff point and to tell the patient that now this is what maximum you're going to get.
So I keep that at around 6 months for my cases. Yeah, that's just my practice.
One workaround for this could be, keeping the overlay and then putting some viscose on top as you finish. So that could possibly, because when we do free flaps, the same problem.
So the retina,
like free ILM flaps or neurosensory grafts, just put a bit of
the
visco
neurosensory
on top.
grafts don't fly off, but these fly off. I don't know,
No,
maybe.
just keeping a little bit of visco.
Yeah, visco.
And then,
Other thing I've started now is autologous blood. We just take the patient's own blood on the table, anesthetist takes it, we take it out and put a blood drop on
Actually,
top.
I was discussing with a cornea surgeon, and they said if you're going to put in an inlay, you might also put an overlay to help the faster migration. I don't know if anybody has done that, but that's a suggestion.
Maybe. Thanks.
So Vendu has a question if you want to ask.
Dada, mic ache.
Next speaker.
Can the next speaker come up, please?
Parveen, you're ready?
We need the
Dr. Parveen said.
So that the luminescence retina overnight the graft will grow and it will build. Like I want to ask you, what is the size of the graft you are taking?
So that's what
Why I am telling you that luminescence graft and AMT, I feel it is a little bit different because the graft size contracts, but AMT don't contract.
Yes, sir.
It degrades. They become thinner and thinner. They don't contract.
So-
That's my.
So Shubhendu, what I think is Dr. Myers has proposed a hydrodissection of the macula. So it's a Myers hydrodissection technique where they go below the macular hole, dissect the macular hole a little bit, and then put in the amniotic membrane graft. And I do not know if you people have done it, but one particular group does it in all their cases for this very reason, that you cannot physically push a graft without creating a space for there.
So size I take is like I showed in the video, the base diameter and MLD, I measure it and I take an average of that because somehow that works. But
I think we'll stop now because there are too many questions. Okay.
So, I think we are really doing, Ajay, you're right, it will give a clear space. So, Andre Gomez had discovered technique 41 gauge. You just lift up the edges, that's one technique. Or, as you said, you use a 41 gauge cannula and subtly inject. So that, and Tamer agrees every time I ask him, is there any problem in tucking? Yes, that's one way of not to dislodge your membrane because you have to tuck whether it's 180 apart or 360 degrees.
Thank you.
Great.